Hi, I think we should get started. So it's a pleasure to introduce today's speaker, Dr. Mark Frye. Mark received his MD from the University of Minnesota, and he completed his psychiatric training at the Semel Institute for Neuroscience and Human Behavior at UCLA. He subsequently completed a fellowship at the National Institutes of Mental Health, and there he focused on the neurobiology of treatment-resistant depression and bipolar disorder. He is currently the Stephen and Shelley Jackson Family Professor in Individualized Medicine at the Mayo Clinic, and he previously served as chair of the department for 10 years. Dr. Frye has established the Mayo Clinic Individualized Medicine Biobank for bipolar disorder. As you probably know, we're starting a new bipolar disorders program here, so we're very interested in that. And so patients contribute blood, they complete detailed interviews, they give access to their medical records, and then they're followed over time longitudinally. And Mark also serves as a scientific chair for BD Squared, which stands for Breakthrough Discoveries for Thriving with Bipolar Disorder. It's a research foundation, and they're also interested in funding these cross-institute longitudinal studies. Mark is president of the National Network of Depression Centers. He's received numerous honors, including the American College of Psychiatry Mood Disorders Award, the Gerald Clerman Senior and Young Investigator Awards from the Depression and Bipolar Support Alliance, and the International Society for Bipolar Disorders Robert Post MD Mentoring Award. So please join me in welcoming Dr. Frye to LIBR.
Good afternoon, everyone. It's such a pleasure to be here at Laureate and in Tulsa. This is a homecoming of sorts for me. My mother and father were born and raised in Oklahoma City, and I had many a trip down to Oklahoma City as a young person, and great to be here with new colleagues and friends at Tulsa. And was just so impressed with our dinner last night and learning about Laureate and hearing about the larger St. Francis health system. There's a lot of similarity with what you're doing here and who supports you, and the work that I do at Mayo Clinic and who supports us. I am really pleased to also recognize one of our Mayo alumna, Dr. Meyer. What a pleasant surprise to see our Mayo trainees doing so well here in Oklahoma. I wanted to spend the half hour or so with you trying to, at a pretty quick clip, give you an idea of what consortiums and partnerships can do. And this is meant to really underscore what I've heard thus far at Laureate is just some incredible research and discoveries and really committed scientists and clinician investigators. And I want that to continue. But I want to give you an introduction as to how that type of discovery science could be scaled or replicated or validated in larger consortium or collaborative efforts. So hopefully you can see how your work could really be channeled or supported in larger initiatives. And I'm going to give two examples of work that I've been very involved in. My disclosures are here. There is nothing from my grant support that will be discussed in today's presentation. I will give one kind of policy statement when I always have to emphasize anything that I'm talking about that's off-label for bipolar disorder. This always, I think, frustrates me to a great deal, and it underscores why there needs to be much more concerted effort in really investigating the depressive side of this illness. The number of approved treatments for bipolar depression pales in comparison to mania, yet this is where most individuals with bipolar disorder live, and the number of approved treatments for bipolar depression is in a different stratosphere than the number of treatments that are approved for major depressive disorder. So my disclosure has a declaration of a number of different points of view. So today, exemplifying the work of the National Network of Depression Centers and briefly, a newer collaborative effort, as Dr. Savitz was highlighting, Breakthrough Discoveries for Thriving with Bipolar Disorder. I want to really highlight to you what the power of a network and measurement-based care can do as we think about trying to better understand the clinical trajectories, the neurobiology of major mood disorders, and ultimately, at the end of the day, how can we help people reduce symptoms and thrive in the lives that they live. Want to give you some examples of what I would call care gaps that we as a field must close, and collaborative consortiums and collaborative partnerships and research are probably the best way to do that. And then give you, again, another small example of how research can inform the concept of individualizing care, precision medicine, trying to use existing treatments with greater precision, and through that work, identifying new targets that might be future novel drug development. So I suspect that I'm preaching to the choir with this type of statement, but let me emphasize thus the last part of this slide. So if we look at the state of mental health care in America, despite our best efforts, and I'm sure the situation is the same in Oklahoma as it is in most of the country, we are inadequately addressing the mental health needs of our citizens. The most up-to-date data from 2024, 25% of adults have experienced a major mental illness in the last year. 25% of those had mentally unhealthy days where they were not able to see a doctor due to cost. Suicide is a key symptom and morbidity factor with this illness. Everything that I've just said is magnified that much more so when we think about young people with emerging mental illness. So the last bullet is really the biggest part of why we think about partnerships and collaborative research. We have barriers to mental health treatment that, while they have improved in some respects, we still have too few trained practitioners, too little research funding, and too much lingering stigma. And I would argue all those are getting a little bit better, but not at the speed or the scale that we need to address the mental health needs of this country. This is the sort of data that really drove John Greedon, one of my mentors and colleagues, to build the National Network of Depression Centers. So I really wanted just to start off and really show you the expansiveness of this network. We now are 28 centers across the United States. We have just welcomed our first international site, the Autonomous University of Nuevo León in Monterrey, Mexico. We are across the country, and we don't have a representative from Oklahoma, which is why I am here today in the hopes that this is of interest to you. My introduction, I will repeat it. The NNDC is not about impeding your individual efforts in outstanding science, discovery, and clinical translation. We want to be a vessel for your work to be replicated, to be scaled, and to have a level of visibility that you would not be able to do as a single site. These are the best programs in the country with expertise in mood disorders, and we see that the power of the network allows us to have a collaboration that really prides itself on novel research, that research being translated into healthcare delivery of new treatments, where we then measure the impact. We just finished a 5-year strategic plan. I'm not going to read the mission and vision every word. Suffice it to say that this focus is on research and innovations that can transform the lives of those living with mood disorders. And our success will be judged by having a world free of stigma where everyone has access to evidence-based mood disorder care. So again, this concept of the power of a network through collaboration, what can we generate from a research perspective that then informs the delivery of mood disorder care, and how do we then measure that impact? These are kind of the goals that we've agreed upon as a network as our 5-year strategic plan unfolds. We will give you some examples of that over the course of our time today, but we really see this as an unending circle. We want research to really inform the practice. We want the practice to we want to judge the impact of that research in practice and learn from that to then generate new research ideas that inform new healthcare delivery strategies. I'm not going to spend a great deal of time with this slide other than to tell you that we've had our board and our members really contribute to what do we want this network to look like in the next 5 years. And I've been honored to be in the role of president for the last couple years, and I saw a really a critical window of opportunity to strategically expand the network, both geographically, but also clinically, the types of sites that we have, the clinicians and investigators that bring their ideas to the network, and how we support them to be successful. John Greedon is the founding chair of the National Network of Depression Centers. He was the chair of psychiatry at the University of Michigan, and he really has been an unwavering North Star as the next iterations of the network go forward. But I've been honored to work with a wonderful executive committee, Jair Suarez, Neil Epperson, Melissa Del Bello, Olu Ajalori, Faith Gunning. Ray DiPaolo was the second president of the NNDC, and I've had the honor of being the third. So let me show you a little bit of what we have been doing. So when I took on this role, I felt I needed to better understand the individual parts of the network. So we, for our 2022 annual meeting, the executive director and I met with every board member, every site, and every department chair that was contributing to the NNDC to better understand who they were as a site, to then understand what we could be as a network. And that data from 2022 that was presented at our annual meeting, with our network, we have identified more than 375 faculty that have funding in any type of mood-related research. That can be an R01, that could be an intramural philanthropic grant through the University of the Department Chair, but a committed number of investigators in mood disorders. We have more than 670 individuals who've identified themselves as an expert in mood disorders care, whether that's a clinician, a psychologist, a child psychiatrist, a geriatric psychiatrist, a large group indeed. When we estimate how many lives we've touched in specialty practices, so this would really be as a subspecialty mood clinic, a depression center, residents that would be supervised by colleagues or faculty with expertise in mood disorders, we've estimated that we will touch approximately 80,000 lives of mood disorders. And when we try to estimate how many lives we're touching when we have our psychiatrists or psychologists that are embedded in primary care, I don't know if that's a system that is available here. We call that integrated behavioral health. That's not a psychiatrist seeing the sickest patients in the primary medicine clinic. That's the psychiatrist really being a resource to the general practitioner, and as opposed to seeing 4 patients in a day, can hear about 40 patients in a day and provide support, recommendations, et cetera. We think we're getting more than 280,000 individuals that way. So I was hearing about these extraordinary numbers at Laureate yesterday, which is amazing, but they're not going to touch the sort of numbers when you pull all these amazing programs together and you have a common set of goals as it relates to research that improves people's lives with depression. We had asked our members to identify what the core strengths of the network were, and you can see by this cloud, not surprisingly, these key points really drive a lot of our work. So I wanted to give you an introduction into our flagship program, and this has been developed now for more than 15 years. It is called the Mood Outcomes Program, and this is our building block for a learning health system. This data has been managed by the L. Tarum Institute, but will be moving to Johns Hopkins sometime later this year. The concept of the Mood Outcome Program was really emphasizing the strength of measurement-based care and following those measurement data over time. I don't know what is available here at Laureate, but all the sites as part of our Mood Outcome Program would fill out a rating scale for depression, anxiety, suicidality, and we track those patient-related outcome measures over time. We feel like we need data points to understand where there are clinical care gaps. Those data points with the clinical care gap that's identified turn into change ideas. And we think about quality improvement. For those who are in the hospital administrative world, think about just multiple quality improvement projects that can be done in real time, if not faster. That's what we see as a potential for our learning health system, our Mood Outcome Program in particular. So to really show you the robustness of this data, since 2015 we have been collecting, and as of 2024, we have more than 139,000 patients that have been followed for at least one visit, and recognizing just the data strength of that number, we've been able to parlay that into a number of key publications that really underscore the morbidity of the illness. But we're now linking this Mood Outcome Program research data set with the electronic health record at the corresponding site, and you can start to appreciate that our power to really better understand and design more effective treatments has grown considerably. Just want to show you an example, and this is a bit antiquated, but this is the sort of data that we have access to with our Mood Outcome Program. So when we first looked at this data, we had some 48,000 individuals that were included. You can see that the majority of them have a primary major depressive disorder. We have about 8,500 with bipolar disorder. The age and the demographics are shown for you there. But we can see that this is a group of some individuals that have at least moderate symptoms of depression, moderate symptoms of anxiety. There is a baseline suicidality that is important to recognize, better understand. And there is a baseline essay here is substance abuse, which obviously is very common in mood disorders. I'm showing you just some example publications that have been that have used the Mood Outcome Program as a data source. And it has been important studies of what really contributes to depressive symptom treatment resistance. In at least bipolar disorder, we have very little understanding as to how depressive symptoms and manic symptoms co-occur and how they change over time. The concept of anxiety has always been linked with depression, but to really see how that contributes to suicidality has been a major interest for the Mood Outcome Program group. What I would say that if I was to summarize for the Mood Outcome Program, so we now have some 140,000 individuals in our Mood Outcome Program. We're now linking that research data set to their electronic health record. We see that we are uniquely positioned right now to really try to answer research questions by having retrospective data on 130,000 people, and at the same time bring them back, or a select number of them to come back for more prospective studies. So the idea that we can better understand the illness with prospective follow-up of people who have 10 years of, 15 years of retrospective data, for us just seems like just an incredible resource. And we are looking for partners in industry and government funding to move that forward, and I'm confident that we will be successful. So as a former chair of a department of psychiatry, every year I needed to pay membership dues for the network. And that was an important exercise for me to really kind of take a step back and ask critically, are my faculty at the Department of Psychiatry at Mayo Clinic really getting an opportunity to invest in the network that is making them better at their job, better at their research acumen, providing networking opportunities they would not have had otherwise? And that answer was a robust yes. And the value of the task groups that I'm now going to talk about, you can't put a price on it. This is the best outcome for membership, is the organically developed, like-minded people coming together saying, I want to talk about college mental health. I think we need to provide a better platform for young adults who are suffering. I want to better understand biomarkers in the context of clinical trial development. We need to be focusing on multiple aspects of women's issues in mood disorder. These task groups, after a due diligence review by our executive group, are asked to build a platform and what do they want to accomplish. And some have really focused on getting grants, which has been amazing. Some have really focused on building policy statements for administrators or for the lay community to better understand the impact of cannabis in mood disorders in young people. And some have really focused on innovative, novel treatment development. It's been spectacular. I wanted to highlight a couple of these task groups and dig a little deeper so you can appreciate the value that's there. Last year, we were given an opportunity from the journal Focus, and this is a journal of lifelong learning in psychiatry that is an American psychiatric publication, and they asked us to really focus on our task groups. So I was honored to write the opening editorial, A Roadmap to Better Depression Care, a Road No Longer Less Traveled. And each of the papers that I'm showing you here was really the result of a task group. Our task groups vary from 10 people to 30. They have a chair. We are strategic about a co-chair that is new in their career, being mentored by a wiser senior clinician. But every one of these papers that you see here was a task group that wanted to better understand anhedonia as a core symptom, depression, and a construct for biological research, comorbid cannabis use in mood disorders among adolescents, targeting research and treatment implications in women with depression, cognitive deficits and late life depression, from symptoms to assessment, psychedelics for depression, between hopes and uncertainties. The task groups defined what was important with the subject matter experts meeting on a regular basis. NNDC provides the Zoom and the transcription, and we have small grants that are competitive each year to really move these projects forward. But this is really a great example. So let me focus on one of the task groups. I've been the co-chair for the biomarkers task group since its inception. And one thing I was really struck by with John was his really visionary thinking about taking seed money and really distributing it to the network. So we had designed a clinical trial for ketamine, and by all means, we're not the first publication to really highlight the benefit of ketamine, but I think we're going to have a unique signature, as you will soon see. So this is a study that was completed at Mayo, the University of Michigan, Hopkins, and Michigan State University in partnership with Pine Rest Mental Health Services Hospital. This is not a complicated trial. This is a open label, 2-week trial of intravenous ketamine, where we had a biomarker that was drawn just before first infusion, a biomarker that was drawn just immediately after said first infusion, a remission assessment conducted the next day, and then a third ketamine infusion within 10 to 14 days. So you could receive up to 3 infusions over a 2-week period. Now, our remission rate proved to be ideal from a scientific perspective, where 52% of individuals at some point in the trial reached and sustained remission. What I find was really relevant about this study is the clinical utility, and it was designed to be impactful from day one. And these research data results, specifically referencing that at the time of first infusion, if you had remission, you would stay at remission up until the 3rd. The second point is probably more relevant. Very few people who did not respond after infusion 1 rarely went on to respond at infusion 2 or infusion 3. So this is really translated into our clinical practice at Mayo and many of the sites. Our clinical service for ketamine is a 3-infusion treatment. And if someone really hasn't remitted by infusion 3, you could argue you could even do 2, we stop the treatment and we just say the pattern of your mood symptoms not responding at this point in the trial or the service would suggest that the likelihood of you having a meaningful response is low, and we think we should shift to something else as a treatment intervention. That's proven to be really valuable, and it's a great example of a research study that informs clinical practice. Sagar Parikh and colleagues from Michigan went on to conduct another really important qualitative interview that I think had clinical impact, and it really looks at the cohort. These are 74 individuals, and follow them up a year after their participation in the ketamine study to see how they were doing. And the thing that was really impactful for me was to recognize that some of these participants, in our eyes, did not meet criteria for response, a 50% reduction in symptoms or remission. But as we know very well, and we're changing the way we think about this when we partner with our individuals with lived experience, a 50% reduction in symptoms means nothing to an individual, if I'm speaking frankly. A number of these individuals who did not have a response or a remission felt as if the treatment was still very helpful. And one of the examples we heard time and time again is my level of anxiety with ketamine treatment was so significantly less that I was able to stop a benzodiazepine, or I was able to stop buspirone. I don't need as high of a dose of an SSRI. I'm not sure clinically I would have keyed into that right away, but this is really where research and partnering with individuals with lived experience gives us a different way to really think about value and treatment reduction. A number of individuals really saw the infusion of ketamine itself, which you may know can have a dissociative quality to it for some, transient, but many found that that state of the ketamine infusion was really a unique opportunity to be thinking more dynamically about issues in their life, and it underscored the importance of clinicians to be ready if that is an opportunity to take advantage of for further therapeutic benefit. So this clinical trial got published in 2024, and to my earlier point, we were not the first to arrive at this party. But I think where we are going to really make an impact is the level of and the robustness of our biomarker development program in the context of this very simple trial. I'm actually showing you work of my mentee, Balwinder Singh at Mayo. He has a career development award that has been looking at biomarkers of treatment response to ketamine while infusing ketamine in an MR scanner, and he had a particular focus looking at GABA and glutamatergic changes that were associated with ketamine remission. What I'm showing you in his pilot data, which was the essence of his career development award, was really showing in real time that in that ketamine infusion, 40 minutes, we see this striking increase in anterior cingulate GABA that is associated with next day remission. And you can see that the individuals in blue who did not have a response, that GABA signal is pretty flat. So this is not an NNDC study, but this study also, in addition to facilitating his career development award, really informed how we were approaching biomarkers for our clinical trial. So again, the concept of a discovery at one site, facilitating a second idea to go forward. We have been working with Rima Kadura-Dauk, a metabolomics researcher, and have pilot data from that study showing that we also have a peripheral GABA signal that is associated with ketamine response. So to me, this starts to get really interesting when we think about the value of a biomarker. A biomarker that's pretty cheap and easy to draw, like a blood sample, is probably going to have more impact than a brain scan that requires coming in to a research center. But to show that we've got that we have both a peripheral GABA and a central GABA, our research now is trying to say, is that peripheral measurement really a surrogate marker of what's going on centrally? And if so, we think that's reliable. Is that the biomarker we should be trying to develop going forward? So individual site data really contributing to partnerships at the network level has been really terrific. These two papers were another clinical benefit of this collaborative research. So our first study was really looking at intravenous ketamine, and this was in parallel to the pharmaceutical development of intranasal S-ketamine. And the data from our study was so compelling that we wrote a position paper really emphasizing we understand and really find it to be laudable to have a novel treatment that can so rapidly reduce symptoms of depression and suicidality, that being intranasal S-ketamine. But this paper really emphasized, don't forget about intravenous ketamine because the data are just as convincing. This paper prompted a number of communications to me as an NNDC leader from insurance companies wanting to better understand how they could try to take advantage of the knowledge base of clinicians finding an off-label treatment effective for depression, and could we think about that for other insurance providers or other clinical examples where they should be thinking about intravenous ketamine. It was a great endorsement to really recognize this clinical research was having an impact, and insurance providers were wanting to better understand what we were doing. The second paper was really taking advantage of the task group. All of these task group members have ketamine clinics at their institution, and they recognized that as a group, they had an incredible amount of knowledge about how to build a ketamine clinic, how to talk to a hospital administrator as to where the service is, what's the business model look like, is this anesthesia, can this be a different business plan? And this has been a great paper for new clinics that are wanting to better understand the best practices of building a ketamine clinic. Let me shift to a personal interest of mine, which is really trying to get a better handle on more effective treatments for the depressive phase of bipolar disorder. This was a case report in the New England Journal that I won't read, but it's pretty typical of the type of seasonal bipolar depression we have in Minnesota, where it's dark at 4:30 and the sun rises fully about 8 o'clock the next day. It's not the cold that's the issue. It is the duration of light that's the concern. So you had heard in my introduction, this is really an understudied area of illness. To my frustration, when you really think about where the lethality of the illness is, it's not in mania. By all accounts, individuals with mania can certainly get into harm's way, but the lethality of suicide is more on the depressive side. We have excellent data to show that people who are only mildly depressed, they're not meeting syndromal criteria anymore, that the subsyndromal symptoms really correlate with a functional disability, and that is what is keeping them from working optimally at their jobs. Healthcare costs for bipolar disorder exceed those of diabetes care, cardiac care, asthma care, and the cost is widespread. It's not one part of the illness. So here's the thing that just gives me such frustration. We have 5 FDA-approved treatments for bipolar depression. There are 12 in the maintenance phase. We have more than 28 FDA-approved treatments for major depression. And if you think about where all the innovative, really exciting areas of depression treatment are now, intranasal ketamine, dextromethorphan, bupropion combination, modafinil, armodafinil, psilocybin, all of these companies have development programs in major depressive disorder, and none of them show any direction of pursuing similar indications for the depressive phase of bipolar disorder. Studying bipolar disorder, with all due respect to my major depressive disorder colleagues, is harder. When you have a depression outcome that is getting manic, that is not good. And I think that is the complexity that I would argue is very manageable and very rigorous in scientific design, but I seem to be a minority opinion. Here's one reason this has been such an important clinical dilemma for us. When you don't have a lot of FDA-approved treatments for the depressive phase of bipolar disorder, you very quickly go into uncharted territory. How many clinicians here are regularly prescribing antidepressants for the depressive phase of bipolar disorder? So I would argue these are the greatest clinicians in the room. You're taking care of really sick patients. The conventional treatments, the evidence-based guidelines, you've been through that, you've done that, it hasn't been helpful, or it's been a side effect issue. So then we start going into using antidepressants. And I remember quite vividly when I was at NIMH, a patient of mine was a hairdresser and was on lithium. I prescribed an antidepressant. She missed her follow-up visit, and her family members informed me that she was speeding, was arrested, and was incarcerated, floridly manic. Now, I have to say that I think that type of situation is less frequent now, and I really applaud our law enforcement officers for wanting to better understand how to more effectively manage individuals with mental illness. But those types of cases, they never leave you when you think about, that was my signature on that prescription. That was my name on that pill bottle, and this is the outcome measure that we've had. So we feel it's been critically important to try to understand what are the clinical correlates that are associated with emerging mania, and can we try to, as an insurance actuarialist, kind of think about compound liability and try to mitigate or reduce those as best as we can. So this was our take of the world's literature on risk factors for a mood switch, using an antidepressant in the absence of an anti-manic mood stabilizer, like an atypical antipsychotic, lithium or valproate. What's really interesting is it looks like this risk tends to fade away after 3 months of antidepressant treatment, and I'd like to show you some mitochondrial energetics data that's very consistent with that. We know that the old tricyclics have much more risk than the newer agents, but the newer agents aren't risk-free. This concept of depression in mania, under-recognized for a very long time, but that is clearly a risk factor. Comorbidity patterns contribute to the switch rate. We know women are at greater risk than men. We know that children and adolescents are at greater risk than adults. This paper got published last year, and to our knowledge, it's the first biomarker under a meta-analysis that shows that the serotonin transporter, one of the genetic variants, specifically the S allele, is associated with antidepressant-induced mania. Is this going to change clinical practice? No. Should we be thinking about biomarkers in addition to other clinical variables as we start to generate risk or treatment recommendations? I think that answer is yes. And so as I start thinking about an antidepressant in a patient of mine, I'm literally going through this entire set of bullets, and I'm counting how many this individual may be experiencing or has had historically. And if I get to a number that I'm uncomfortable with, I'm not going to use an antidepressant. I'm going to be thinking about lamotrigine. I'm going to be thinking about cognitive behavioral therapy. I'm going to be thinking about something else. So the title here is really trying to have pharmacogenomic targets be of additional value. It's never going to replace a good clinical examination. So I had mentioned the Swedish registry study showing that the risk of an antidepressant-induced mania without an anti-manic mood stabilizer, that risk tends to fade away after 3 months. We were very interested in where my arrow is here. One of our bench scientists at Mayo had been very interested in thinking about mitochondrial energetics and how that might be contributing to the illness of bipolar disorder, or how psychotropic medications may impact that. And in a very robust review of all preclinical experiments, they generated these 3 columns of psychotropic drugs that had generally increased mitochondrial energetics. So at any point in the electron transport chain from complex 1 to complex 5, if the data was suggestive that when exposed to paroxetine, mitochondrial energetics increased, you get into the green column. So we were very keen on thinking about paroxetine. Contrast, preclinical data that would suggest that the drug is actually decreasing mitochondrial energetics, and again, we really focused on escitalopram. This was a pairwise contrast that caught my attention. When we talk about antidepressant selection with our patients, we are using a categorical system that is woefully antiquated. The concept of an SSRI, a tricyclic antidepressant, this is 75 years old. And our thought was, clearly, there's got to be a better way to be thinking about psychotropic medicines and what they are doing to neurobiology, or in this case, mitochondrial functioning. So with this as a guide, we have a bipolar biobank at Mayo that is looking at 2,000 individuals who've been gracious enough to partner in research and have been deeply phenotyped. And we have a phenotype of antidepressant-induced mania. And we simply looked at our clinical data set and said, is the rate of antidepressant-induced mania higher when the antidepressant has been shown in preclinical studies to increase mitochondrial energetics? And that answer was robustly yes. What I'm showing you here is the antidepressant-induced mania signal is significantly higher in antidepressants that have been shown to increase mitochondrial energetics in comparison to antidepressants that have been shown to decrease mitochondrial energetics. Should we be doing mitochondrial functioning on every patient before starting an antidepressant? Of course not. But I think this is pretty compelling data to highlight that the days of thinking of tricyclic, selective serotonin, mixed serotonin, norepinephrine, reuptake inhibitor, that these categories need to go. There are so many meaningful ways to think about drug mechanism of action, and a lot of our work is really focusing in the mitochondrial realm. Let me take just 5 minutes, if I could, and introduce you to a brand new transformative collaboration that is called Breakthrough Discoveries for Thriving with Bipolar Disorder. This is about a couple years old now, and it is an immense effort to harness genetics, omics, mechanistic discovery grants to better understand the neurobiology of bipolar disorder, and doing so, learn how to take that new knowledge in a learning health network to improve care and improve lives of those living with bipolar disorder with the goal of thriving. I have been honored to be the co-director of the Scientific Integrated Network, and our goal is to really take this data that it generally takes about 17 years in this country to go from a scientific discovery to a clinical intervention. We think the network with a research cohort protocol embedded in a learning health network can give us those discoveries and translate that into faster care. I want it to be 17 months, but I think anything significantly less than 17 years would be acceptable. This is really the essence of our integrated network. We launched in 2023, and part of our study is what we call a learning health network, and you're going to see some similarities to our mood outcome program data that I had showed you before. Our BD squared network is going to really focus on producing standardized data from routine clinical practice, large scale. We're going to follow 4,000 individuals with bipolar disorder for 5 years, and every year they come in for a research visit, and we also track their electronic health record looking for care gaps. Who's doing well? Why is that? Who's doing poorly? Why might that be? If we see these data points that seem to associate with doing well or doing poorly, can we try to develop a change idea or a quality improvement project that can learn from that new knowledge and hopefully improve practice and people's lives? This is probably the best way to really show this in summary. So we now have 11 sites that are in the network. And each site, when they invite participants to be part of the study, will have a blood draw, a brain scan, cognitive testing, a Fitbit, and access to electronic health records. And everything is standardized at each site as to how we're collecting that data. We have a data coordinating center that data quality checks, aggregates, and harmonizes the data. And then we bring that data back to our sites to start looking at general insights and looking at the data for care gaps, for new knowledge. How does that care gap or new knowledge, how does that new knowledge inform the practice? And much like what I was highlighting with the national network, can these findings be scaled to a larger level across the United States and globally? First, look at our data. We have, and this is with the first 548, we've just locked the study at 620. But you can see that the average age of onset as an adolescent, age 17, individuals have been ill for 24 years. 4 prior psychiatric hospitalizations, 1 prior suicide attempt, at least 2.5 medications. So this is really just a snapshot of the demographics, but we now are looking at the research data that was collected, the electronic health record data, and I think you'll start to see a lot of that data come out here in 2026. So my conclusion slide, hopefully some time for questions, is the introduction that I've had to Laureate today has been amazing, really impressive, the good work that everybody's doing. I would have you think of partnerships and collaborations as how can we scale the discovery work that you have brought to the field. These are the ways that we can scale precision medicine initiatives, better understand, and importantly, disseminate best practice models, understand and address healthcare gaps, and hopefully educate the next generation of clinicians and scientists. I want to thank you for your attention. And as I have Martin come up, if there's going to be a Q&A, I just want to recognize all the BD Squared sites and leadership that you see here. I specifically wanted to invite you to our NNDC reception at the APA this May 16th. We have our annual research meeting of the NNDC next year, October 19 in Austin, Texas, and we'd love to see you there. Thank you very much. Any questions or comments? Martin.
I think it's great, both initiatives, great initiatives. We really need this coordinated effort from multiple sides. I had a question about BD Squared because it still is my understanding that the core study will focus primarily on bipolar 1 individuals. What are your thoughts about, expanding that to bipolar 2, because that's a significant subset of the bipolar spectrum?
So there were several years that this discussion went forward as to how narrow do we want the phenotype to be. And I think the decision was, let's start somewhere and be committed to really understand that. I think for the foreseeable 5 years, it will be a BP1 cohort. There is the intention that this is going to go on for decades. So I would think it quite likely that at some point in the future, not near future, there would be the expansion. Which is important because I think you're probably alluding to this. Is bipolar 2 really kind of this intermediate between BP1 and major depressive disorder? It's a different illness. So for example, when we look at just the rates of antidepressant-induced mania, BP1s have a much higher rate of this adverse event than BP2s, and the BP1s are on more anti-manic mood stabilizers. So there's got to be something fundamentally, either the comorbidity profile or something about the illness that is delineating such a different adverse event profile with the antidepressant. But there's a lot we need to do, and I think there was a goal to really be strategic and narrow initially. All right, a very good afternoon to you all. Thank you.